rewards clinicians, but also gives the public what they really need, which is really good, high quality mental health care that's long term, it's comprehensive, it's multidisciplinary, and it also addresses people where they're at.
Hello and welcome to another episode of Be an Awesome GP, positive conversations in general practice. Today I am very excited to be sitting down with Dr Terrance Lim, or Terry. Terry Lim is an highly experienced consultant psychiatrist specialising in complex psychiatric illness treatment. He has over 14 years of expertise in both public and private mental health sectors and is now currently working at the Mindsight Clinic, a premier mental health clinic located in Gordon, Sydney, Australia. Their mission is to deliver top quality mental health care, enhance mental health literacy, and their health GP program, which I'm very excited to get into, led by qualified general practitioners working in a multidisciplinary team, is doing very exciting things in the ADHD space. Terry, welcome to the show.
Thanks, Chris. Great to be here.
So can you just give us an overview of the Mindsight Clinic and what you guys are doing? Because that is really good stuff.
Sure. Thanks, Chris. I'm really excited to be talking to you all today and to my GP colleagues. Just a bit of background, a bit about myself. As you said, thanks very much for the intro. It's very kind. As you said, I've been in sort of public and private practice 14, 15 years now, including my training. So I've trained in Sydney, went to med school here as well. Training is 5 years in psychiatry, and it's mostly purely in the public sector. Doesn't prepare you very well for the real world of private practice, unfortunately. So after getting my letters, I went straight into pretty much private practice, along with some public practice work as well. It's a bit half-half. So my specialty training is actually in consultation liaison psychiatry. So that's my kind of first love, as it were. So I've always had an interest in kind of neuropsychiatry, the sort of mind-body kind of relationship, that kind of thing, which really lends itself well to psychiatry. So now the first day I got into private practice, someone asked me, "Do you treat ADHD?" I said, "What's that?" And 11 years later, I've been treating it for the past 11 years or so in private practice. Switched over to full-time private practice a couple of years ago. I was working at a private hospital with a group practice attached to it. And about 13 months ago, decided to start something new with the intention of doing something a bit different. There are several psychiatry practices around, but I wanted to do something that gave me the freedom to innovate a little bit, as well as run a practice the way I wanted to, because I see a lot of deficiencies in how most psychiatry practices are run, unfortunately, and I wanted to address some of those frustrations in day-to-day practice, but also, as I said, give myself a platform to try and do something innovative in kind of the broader mental health treatment space, because as everyone's keenly aware, there's a lot of structural problems, a lot of service delivery problems. And one of the things I had from day one was the vision to do something that would go some way to address that. So the Mindsight Clinic was born, I guess. Most of the past 12 months has been focused on running a good practice and building a good team of clinicians, which we have. So we have 5 psychiatrists, 2 clinical psychologists, and a mental health social worker. We've got a great team of admin staff and a great practice manager. So we've grown pretty fast in 12 months, and it's allowed me to, lend some brain space to thinking about innovation. One of the things I've always wanted to do was to build a multidisciplinary and multi-level mental health service that's based in the private sector. I think that there's certainly a place for government mental health services, but I think everyone knows the limitations that they have in terms of resourcing, funding, that kind of thing. And what I've found as well that in the private sector, the main model there is really private hospitalisation and outpatient groups run through private hospitals, which again I think is pretty limited. And there's nothing really in the outpatient space. There's so much fragmentation, Chris, in our mental health service. There's turf wars, there's philosophical differences, funding differences, all sorts of things. So I wanted to fill a space where it's privately funded, of course, with the Medicare kind of structure behind it, but that rewards clinicians, but also gives the public what they really need, which is really good, high quality mental health care that's long term, it's comprehensive, it's multidisciplinary, and it also addresses people where they're at. Not everyone needs to see a private psychiatrist, but unfortunately, the options are at the moment your regular GP, maybe a psychologist, or a private psychiatrist. Try and get any other help, but you need to be on death's door, as you know. Yeah. So that was the philosophy behind what we're trying to do here. And the mental health GP program is the backbone of that thinking and innovation, I guess.
Because I know most of our listeners would really resonate with what you've described, the idea of seeing that you want to do something more elegantly in a private solution and pursuing their own practice so they can set it up the way they want to. And I'm sure, I'm sure as you're aware that private practice comes with its own set of challenges and running things. And we are struggling. We are trying to find solutions for mental health patients because the system is at capacity and beyond capacity.
Yeah.
So it is really an exciting area to find solutions. And sometimes in the greatest crises, we do find the solutions, which is part of why I wanted to chat to you, because you're someone looking for solutions. Tell me a bit about ADHD, because that's been very topical lately. There's been a Senate inquiry into ADHD.
Yeah.
There's been a lot of talk, but tell me a bit about ADHD and what you guys are doing there.
Sure. Well, I'm conscious that I'm speaking to learned colleagues, so apologize if anything I say is a little bit obvious or simple.
We love obvious and simple.
So to put it in a nutshell, ADHD is what we call a neurodevelopmental condition. So essentially, it's to do with how certain systems in the brain develop compared to the rest of the population. So it's a standard deviation type of concept. And really, it's a mismatch between the brain's ability to function in the executive functioning realm compared to what the environmental demands are. So there's quite a complex etiology in terms of there's a genetic component, but more and more we're sort of recognizing that the environment which someone grows up in, especially in those early years, really affects the phenotype of how people present. So I guess it's interesting because in the child space, obviously, most people know that ADHD falls in the realm of the pediatrician, which has always interested me because to me, it's very much a psychiatric condition. I personally see it more as a disability, or it can be a disability rather than an illness. So the treatments and the approaches really, to me, have a disability management kind of focus rather than a illness treatment type of thing, which I think maybe my medical colleagues have more of in terms of the way they approach things. So we are trained very much in a holistic biopsychosocial, cultural, spiritual type of model. And so when I talk about something like ADHD, I think the difficulty people have is that they tend to see this condition in isolation. But really, ADHD is really a contextual condition, and it does go a little bit to culture. But I won't spend too long. But really, the condition has crossed, cultural and historical boundaries. There's descriptions of ADHD as far back as the early 1800s from pediatricians back there. So it really has a long history as a syndrome and as something that causes significant disability from childhood. I think what's being more recognized, though, is the burden in adult ADHD and adult sufferers. And I think that's where the controversy, I suppose, may lie, where the explosion is in the adult ADHD space. And I guess the general difference between diagnosing and managing people in the adult ADHD space as opposed to the child space is that comorbidities really are the rule for adults with ADHD, especially if they haven't been treated for most of their life. We know that most neurodevelopmental conditions benefit from early intervention, whatever that is, whether that's a learning disorder, whether that's autism, ADHD, all sorts of things. So early intervention is really the rule. And a lot of adults who get diagnosed later in life have missed out on a lot of that early intervention. So their burden of morbidity is often higher, and their burden of comorbidity is also higher as well. So they often present with secondary mental health problems, depression, anxiety, that kind of thing. They often have the burden of complex post-traumatic stress disorder or complex trauma from young, which hasn't been addressed. And they often have higher rates of physical comorbidity as well. Poor diet, poor sleep, chronic stress, higher rates of substance use, higher rates of even things like motor vehicle accidents. There was a study done on a group of high trauma motor vehicle accidents, and significant proportion of those people had ADHD. That was kind of screened for. So adults with ADHD often have suffered for many, many years before they seek treatment. And what we find is that treating adults with ADHD is really rewarding, because often they've been misdiagnosed or they've been treated for a secondary problem, and the primary issue of the untreated or the unhelped, as it were, neurodevelopmental disability has been missed. So if you don't correct the disability, it's very hard to address anything else. And so people end up in the revolving cycle of getting the results of ADHD treated, or sequelae of ADHD treated, but not having the actual condition treated itself. So once that's been addressed, people then go on and really make a great fist of the other stuff that they struggle with, which is often the richer part of the person, actually, rather than the ADHD itself.
Because I imagine you've probably had the experience where you're assessing a family member for ADHD and you notice either the father or the child are showing ADHD traits because of the genetic component. Tell me more about how it can shift the trajectory of someone's life, because you sort of see people who get treated as adults for ADHD and you wonder what the trajectory of that person's life might have been if they were diagnosed earlier.
Yeah. Well, Chris, it's a great point you raise. Often when a lot of people go, oh, look, I've looked it up on Google, I've watched a TikTok, and I'm pretty sure I've got ADHD. Now, when someone comes for a good assessment and they get given a really good explanation for why they've suffered and struggled for most of their life, whether it's ADHD or whether it's something else, often the relief for people is quite palpable, especially if there's hope, that things can be better and things can be improved. And if they do have ADHD, the good news is that ADHD is something that can be very effectively treated. I mean, I was reflecting on this, and there's not many things in medicine with the evidence base and with the sort of odds ratio of effectiveness of the medications and the treatment protocols that we have in ADHD. It's unbelievably robustly studied in terms of evidence base. If we had the same outcomes for anything else, we'd be stoked. So really the relief, but also often we get reactions of grief. The what if kind of question, comes pretty soon after the initial relief, and the grief of what could have been, and often there's a lot of work to be done around that, around kind of often it's a renovation of one's sense of self. It can be that profound, the idea that one is not deficient, or one is not lazy or difficult, or or dumb. You know, these are sort of things that people carry all their lives because they have a disability that wasn't seen and picked up. So when that's given to them as an explanation, if it's accurate, then it can lead to really profound changes in someone, and it takes time sometimes to work through with people, even if they're on medication.
One of the things I wanted to talk to you about, and I could actually get into this for quite some time, but I know we're on limited time. You guys have mental health GPs at your clinic who I think they just do that, and they're very extensively trained, and you're making use of that. Can you tell me a bit about that for our audience?
Sure. Well, Chris, I'm really excited about this program. So I was racking my brain about how to address this sort of structural mental health issue. So just to be clear, when I talk about our mental health GP program, this isn't just about ADHD. This is about mental health. And mental health is an interesting field. It has a lot of medicine, but it doesn't have a lot of medicine, if that makes sense. It's a different beast. And to apply the usual kind of models that we have in healthcare to mental health, it doesn't really work. So really, what mental health treatment needs is a truly multidisciplinary approach. And to me, the epitome of a holistic practitioner is a general practitioner. The training, the breadth of training that mental health, that GPs have, and the depth of knowledge is really under-recognized. It's underutilized, and it's taken for granted. And it really makes me angry, actually, to be honest. The way the public views our general practice colleagues. And it just struck me that, psychiatrists are a very scarce resource, and they're often overkill. But if I could tap into my general practice colleagues and just put it out there whether anyone would be interested in working within a specialist mental health clinic, just doing mental health care, being rewarded for it financially, and it has a passion for it. So they're getting trained, and they're getting supervised, and they're getting supported, whether there'd be interest. Now, I had no idea, Chris, how that would land. I put it out in one Facebook group. It was rubbish. The GPs there were like, it's never going to work. And, who'd go and refer their patients to another GP? You're going to be seen as stealing people's patients, and all sorts of stuff. And I was like, oh God, it's a bit depressing. So then,
wow.
But I didn't give up on it. And I thought, but I really struggled to know where to find these GPs. Anyway, so I kind of sat on it for a bit and whatever. And then I put it out in another Facebook group, an interesting group called Creative Careers in Medicine, funnily enough. So I put it out there. And I got a great response. I had about 30 or 40 GPs saying this would be a fantastic idea. And someone then posted it to a group called the Australian Society for Psychological Medicine. I think it's a large group of GPs who are interested in mental health care. So someone put it out there. I had an information evening. A few GPs joined on. And now we have 2 GPs that have started from July when we kicked off the program. So they're both part-time. One of them has decided to give up their general practice, which was a bit scary. I thought, hang on, and the other one still works in general practice as well. So what the model is, Chris, is that they just do mental health treatment. Now they can do some basic, or they do have the scope to do basic health screening, but really I want their time to be used to treat mental health conditions. And so the idea is to partner with their usual regular GP, right? And really what it is, it's to plug the gap between the average GP who struggles to treat mental health conditions properly in the community, not necessarily because they lack the knowledge or ability, but because of how our Medicare system is structured. And the gap between them and having to see a psychiatrist, and the wait can lead to so much extra burden of morbidity in the individual, but also in the healthcare sector. and risks the individual ending up at the worst case scenario in the mental health unit or in the emergency department if they don't get timely care. So I thought, the GPs are perfect for this. You don't need a referral. You can walk in. You can make an appointment. And really the standard of care that I'm seeing from our two GPs is not much less than what the average psychiatrist would offer, to be honest, especially with the support and with the training and with the case conferencing. So we have a fortnightly case conference. We a supervision time. They join our monthly supervision with other psychiatrists as well, or peer review, and they're loving it. And it was a bit slow in the uptake because it's such a new model. I've had to really try and educate the public and other GPs, which is why I'm really thankful for this opportunity. But it's been definitely gaining traction now. Our two GPs have seen about 50 new patients between them in the sort of 1.5 sessions that they do here, and these are new patients who otherwise would have been waiting months to see a psychiatrist. So I'm really excited about that. Not only that, but they follow up these patients. Yeah, they follow up these patients as well. I can let them follow up some of my regular patients that are kind of like clogging up my books kind of thing, in that sense, in the nicest possible way, so that I can see more complex patients. And so we're the vision really is to build a stratified mental health service where psychiatrists are used to see the most complex patients, and the general practitioners, the mental health GPs, are here to can see the bulk of patients that are otherwise don't need to see a psychiatrist. It's more cost effective. The standard of care is, in my mind, just as good. These are GPs that have obviously fully fellowed, but they've also done extra training. They're really passionate. One of them is doing a master's of counselling. So I'm really excited. We're about to bring on another GP in the new year. So I guess I'm super excited about it, Chris. And I personally think I'm a bit biased, but I really think this could be an answer, a big answer to the structural problems that we're facing right now in the mental health service delivery.
I think it's an excellent answer to many of the problems we're facing. And I think the fact you got such a strong backlash when you first proposed the idea, in many ways suggests you were onto something. I think when you come up with a great idea that changes the system, often the haters will hate. I think I'm glad that you went to the second Facebook group for further feedback, because there will be a lot of people very interested in this model. And I will actually start to wrap it up there, Terry, because I'm on a bit of borrowed time. But I think I'd actually love to come back and chat to you in 12 months or so when we could see how you're going, because this is a very exciting field. This is an evolving field, and I'm sure you will have excellent results in 12 months' time with this model.
Sure.
If people do want to refer to your clinic, or if they want to find your clinic for more information, where is the best place for them to go?
Yeah, look, the best place to start with is our website. So mindsightclinic.com.au. Our physical location's in Gordon, in the North Shore. But, in this day of telehealth and mobility, really it's just where we've ended up. But we see patients from the whole catchment. If people are interested in finding out more about the model, there's a lot of information there, and also what we do. And if they would like their patients to get mental health care that's really good in quality, and they can't wait for months and months and months, it doesn't have to be about ADHD. It could be anything. They feel free to put their patients onto us.
All right. Well, you have a lovely day. And to all our listeners out there, remember, you are an awesome GP. Be an Awesome GP is targeted at general practitioners in the Australian context. It should not be taken as formal medical advice, and you should consult your own clinician for any medical matters. Opinions are those of the presenter or guests and do not necessarily represent any organisations.